Welcome back. And the next session, tackling the gender bias in health data and services. And the moderator for this is Karoliina again. But before I do that, I just want to make a quick point. In the last session, we talked about bias in data. This whole panel is about bias, and it is fantastic to have an all ladies panel. And I'm also really pleased that Karoliina beat me up after last year to make sure that in the total number of speakers at our summit, we have one more woman than we have men. So over to you, Karoliina.
Thank you so much, Vlad. And yes, we are very happy to have ladies here with me. I just want to make a disclaimer that we don't want to make it as the feminist session. We are discussing here the topics that are very important for women, decision makers, researchers. But yes, we are tackling the gender bias in health data and services. And as the word of introduction, I don't know if you know that only in 2019, WHO global health statistics were disaggregated by sex for the first time. While this is a very big step forward, isn't it a bit too late? And since the emphasis is also on data-driven designs, is there sufficient awareness of data bias when using them? From cars that are 71% less safe for women than men, because men have belly and women don't, to voice recognition technology that is 70% less likely to accurately understand women than men, and to medication that doesn't always work for women the same way as for men, for example, because of the hormonal changes during the period, because women were not invited to the clinical tests. So there are some points, very important points in this discussion that we will handle today. And I'm very pleased to introduce our experts today. We have Jenny Thomas, who is an advisor to health tech startups. She led the setup of Digital Health London and ran their internationally renowned health tech accelerator for several years. We have also Maria Isabel Iñigo Petralanda, research ethics, who is the member of the Research Ethics Committee at the Pontificial Catholic University and Argentinian Ecosystem Coordinator. And joining us from Finland, Karoliina Snell, who is a university lecturer in University of Helsinki and deputy chair of ethical review board in the humanities and social and behavioral sciences, as well as a member of ethics advisory board of the Finnish Center for International Intelligence. I will let now our speakers to introduce themselves a bit broader and to let us know what is their particular interest in the area of gender bias, what is their area of work. Maybe we can start with you, Jenny.
Great, thanks so much, Karoliina. Thanks for inviting me along today. I've always been really passionate about women's health. That's been a thread throughout my entire career. From after university, I spent some time in India, in rural India, in a girls' school working on women's health education up until about 6 or 7 years ago when I was the general manager for women's at Guy's and St Thomas's. And more recently, I've been really interested in the space of women's health and digital health. As you said when you introduced me, I previously ran the Digital Health London Accelerator. But I would say much more recently, the area that I'm really passionate about is actually a gender-informed approach to healthcare. In the UK, we might talk about this a bit later, in July, a women's health strategy was launched. And that's, it's a really fantastic strategy in that it shines a light on the importance of women's health and the areas of women's health that require real attention and what could be done about that. But I think what's also really interesting is that increasingly there are calls for a men's health strategy and a trans health strategy. And actually there are points of access of healthcare, or when you look at health outcomes that are actually very different depending on what gender you associate with. And I think that, you know, on this panel, we're particularly looking at gender, but you can actually frame healthcare through lots of different lenses, whether that's ethnicity, geography, sexual orientation. And I think gender, and as you said in your introduction, Karoliina, really kind of disassociating that data and looking at it so that healthcare can be planned in the most informed way is really important. I'm very passionate about this particular topic. Thank you.
Thank you so much, and happy to have you with us and hear your views on some of those issues. What about you, Maria Isabel? What is your background and interest in this topic?
First of all, thank you for sharing this nice place to share knowledge, and that's why I want to focus on this. I love knowledge. I love in my daily routine to find solutions to different needs. That's what science do, to pick up a proper and evidence-based solution to try to solve things and to try to reach truth. As we have been saying here before, sometimes we find biases on this regard when we are going towards to find the truth and to find the problem and to give a proper solution. That's why scientific work for. And in a whole criteria of justice, that means that every portion of everyone in criteria of justice should be represented. At the same time, we have a big problem because bias is a natural condition of researchers. Researcher goes straight forward to what he or she is looking for. So there is a very important opportunity in this digital health scenario, and particularly in this summit, that we can speak about these problems that involve committing biases. And it's not, as you said, Karoliina, previously in our talk, an issue of feminism. It's not just a reductionism of that. It's much more. It's vulnerability of cross-border issues. Pandemic COVID showed that women cannot be part of, research, of papers. The representation of women was less than 20%. And that's a big bias because they are householding according to Pandemia. So Pandemia was also an experiment on that regard. So I'm fanatic of justice criteria, and that's what Ethics in Research Committee do, a bidding opinion on that regard.
Perfect. Thank you so much for also bringing some of the important points already to the discussion. Like researchers are looking for what they're interested in. And Karoliina, to you.
Thank you very much. Yes, we're all female panel, and we're almost half a Karoliina panel as well, which is great. So I'm Karoliina Snell. I'm a sociologist. And my research interests are in sociology of health and also science and technology studies. And I've been doing research for a long time on sort of very many social aspects and meanings of genomics, biobanking, biomedicine. And all of these are very much sort of a population-based, population-level efforts. And one of the questions always comes like, who are included and who are represented in these populations? And this is something that sort of through this, I become interested also in the sort of medical or biomedical bias. Most recently, I've been doing research on different ways of gathering, using, and understanding the possibilities of health data. And we have this huge project on data literacy. And in this sense, we were sort of trying to understand the whole functioning of like, where does the data come from, how it's produced, how it is analyzed, how decisions are made based on that data. And we need data literacy, understanding the data, and for example, the biases in the data in each of these processes. So in a way, this is the sort of a current way of way I want to sort of see, well, how can we understand the biases inherent in different types of data? And then, as Karoliina also said, and Maria talked about the ethics, I'm into, I don't know, research ethics pro, more or less. I'm in several research ethics boards, social science and humanities, artificial intelligence, clinical trials, and all of these sort of are given interesting glimpse on how data is being used and understood. So even though I do the ethical evaluation there, in a way, it also helps me to understand the different aspect there is to sort of, for example, gender bias in data. And I'm very much interested also in the sort of many ethical aspects of data. Thanks.
Mm-hmm. Thank you so much, and for this introduction. And here we wanted to ask all of our audience for their opinion of what do they think is the most important root cause of gender bias in health data. Unfortunately, we are not able to launch the poll, but we are eager to hear from all of you in the chat if you can comment to us. But I will then ask my panelists here in the studio. So if we have to choose for the root causes of the gender bias between lack of awareness, haste and carelessness, lack of resources to secure good quality data, and unwillingness of people to share their data in surveys and interviews, underrepresentation of women in health research, or maybe there is no problem. So what would you comment? What do you think is the most important root cause of gender bias in health data?
Well, the whole of us, unfortunately, the whole of us, because it's an anthropological issue. We are in the middle of a big change of world. We are dealing with data faster, and we are modeling and designing the thinking. We are modeling our knowledge. So you have all of them. The anthropological and technological dimensions are cross-bordering. That's why. So the quality in data, interoperability, and standards are like three keys, and data sharing, of course, because you share, and if your mindset should analyze responsibility and stewardship rather than property and not sharing. So that's the big combo, and you will understand all the problems that you mentioned, Karoliina.
Thank you. What's your experience tells you, Karoliina?
I have to agree. It is all of them, and they all interact and reproduce each other. And what I would also say, like, it also depends on the type of data. We cannot just talk about that there's one type of data and one sort of root cause of bias. We do have different types of data, and each of them might have different types of biases and causes for them.
Thank you. And Jenny, if you would have to choose.
So again, I would say that obviously all factors play in, but for me, the one that I would choose actually is awareness. And I would choose it because I think that's the one that would make and it is making the biggest difference in terms of actually tackling and changing. I think if people, I know when I hear statistics about the experiences of, say, Black mums during pregnancy, and the outcomes, and it's shocking. And I think if that plays through across, as I was saying earlier, this gender reformed approach to healthcare, then actually when people realise that there are these real differences, then they'll want to know what the data is telling, and they'll really want to make sure the data is being collected. And then there'll be kind of incentives that go around that, resources, as you were saying, as one of the options, and willingness and curiosity, and that everyone will place more importance of it, and it will feed through into policies.
Thank you so much. So this shows that we are dealing here with a very complex issue, and it will be quite difficult to choose one priority for action for future action. But I think, like, with this awareness raising, hopefully this session is already one of the good first steps. And now moving on, Karoliina, you mentioned that your interest is to understand that there are the biases in the data that we use. And can you tell us a bit more? How can we identify and understand that there are the biases, and also from health biases, what other gaps can you mention when we think about the quality of data?
Yes, well, maybe I would like to continue from what I said, that there are many different types of data. And so if we want to understand the biases, we need to go into all these different types. And like, what do I mean with different types of data? Okay, we all know that clinical trials, there's a sort of overrepresentation of men and underrepresentation of women. We might also know that registers have a sort of a bias in that sense. Like, well, in Finland, we are like the promised country of register. We have so many public registers of health-related data that can be easily combined, and they cover more or less the whole population. But of course, there the gender is binary, and of course, this already causes something. But these are something that we know about. The causes, what there is, what kind of biases there are, or what kind of a sort of a underlying assumptions there are in data. But when we come to more of these types, when you go to all these new types of ways to produce digital data, whether it's electronic patient records, whether it's self-reporting through apps, patient-reported outcomes, we have to start to look at inside of these practices. Like, for example, if you think about apps, it is a question like, who is developing the apps, to what kind of audience? Is sort of the gender aspect taken into consideration or not? What kind of questions there are? But also when it comes to sort of data or digital labor people are doing, there might be differences in how women and men or other genders engage with apps, interpret what is being asked from them. We do know that women, for example, report differently than men in the literature related to patient-reported outcomes. There's sort of a physical, for example, pain is reported differently. So we do know something, but we do not know that much yet how people actually engage with all these new digital technologies and what kind of very sociological things there are behind answering surveys or sort of carrying whatever pedometer or something with you or leaving it behind. From my own research, one of the sort of example I love is also like way people engage, patients engage with doctors. I did a research on people who received a genetic risk score for getting cardiovascular disease. And then I asked if they had talked with their doctor about this. Mm-hmm. And then there were women who said that, oh no, I didn't want to impose my doctor with this sort of information. So we have to sort of start to think about the social engagements as actions there are and this, like, if there would be something, this might have been recorded in patient record, but in this case, not, because it was not taken as part of the sort of a patient-doctor interaction.
Right. So,
but there are many other examples as well.
So yeah, so we have to be empowered ourselves to actually like bring some aspects to the surface. But now, when we know that there are the gaps, I would like to ask you, Isabel. You are also a researcher. Why we are still failing in collecting this data? Why we are failing to uncover this whole layer?
No, it's a typical question. As Jenny said before, and Karoliina too, I guess that we all agree on this regard. And in every point of this meeting, I guess that there is an opportunity of two important things. Karoliina said something recently. Qualitative research, for instance, is something that helps you to measure all these things that you cannot reduce to 0 or 1. So methodologically, all the quality of anthropological issues, as Karoliina said before, how you can learn systems, how you can deal with data, analyzing data, because nowadays we are data analytics experts in all transdisciplinary bases. And that is something that has to do with literacy. If you don't understand how data interact and how we share data, we are from the very recent step. So we are educating people in a sociological dimension and a change of paradigm. So you have to be kind of strict when we do science to make the sample of the research the more equitable as possible. That means to include everyone in the sample. And how can you know if everyone has been included if only quantitative metrics are being taken? So a great solution is to finance, and that's a problem, another problem, the grants that we receive that inherit all the biases before existing. So women don't receive, or vulnerable researchers do not receive grants to keep on going on this regard. So qualitative research is not being developed, and all these gaps are taken from narrative. That means taken from narrative of thanks God, according to this tool that is the technology and communication data that you get from other aspects that do not come from research field itself. So qualitative, it's something that we have to work a lot, and that is very important to be financed too, to receive grants too. And women should have decision, not only be named in the board of researchers, but also make the voice and the decision go into not only the call of action, the proper action, woman deciding of what is going to be research.
And then Jenny, so here we have the view of the researchers, and Jenny, you advise the startups, and you also work with the public sector when often this research and the results of the research translate into services, products in the case of, for example, startups, or in the case of the public sector, it translates into policies. How do you think, where do you think is a bit of a challenge or a potential pitfall when the inaccurate data, the inaccurate results might bring the policies that are, yes, inaccurate, or the services that are not serving the purpose?
Yeah, thanks. Yeah, I guess thinking of some examples that probably everyone would be familiar with. I mean, you could take the case of public health messaging. If you looked at, say, the symptoms that men display when they have a heart attack versus a woman, they're quite different. And perhaps particularly in the past, that it's been more the sort of male symptoms that have been shared. And so maybe the symptoms that a woman shows are less well known. You could also say that you could take kind of breast cancer awareness, and if you don't think enough when you're kind of making policies about kind of the different ways that different ethnicities kind of interact and look at imagery. If you say have an image of a white woman and you're trying to raise awareness about breast cancer screening, that might not be the best way to engage. Although certainly wouldn't be the best way to engage other populations. So I think that there's those sorts of things which are where you're not using data appropriately. But I also think you could kind of look at it a step on and think, well, actually, how could there be more, if there was more awareness about conditions like, say, the menopause or endometriosis, more data about women specific conditions, then actually maybe there would be policies and government kind of recommendations around, well, how do you record, say, menopause, sickness, absence in the workplace? So there was more awareness of the impact that would have, and the impact that women leaving the workplace has on businesses, and also on the economy as a whole as well. So there's, yeah, I mean, and obviously can play through into the design of healthcare services as well. If you're thinking only through one lens about kind of how different people access services or prefer to access services, and and of course through to outcomes where if you're saying to someone that you need to present if you're showing these symptoms, whereas actually if you're a different gender you need to present if you're showing these symptoms. So I think it's absolutely huge, and there are lots of different ways you can look at that, and it's really important. I'm really pleased that in the UK there's so much more of a focus recently on health inequalities, and that's really kind of a kind of policy level. And then I absolutely see that through, and have seen that feed through to the startups that I've supported, whereby business cases that have been presented where it's about kind of adopting a digital health solution. Decision makers are asking questions like, well, what about those that can't access digital? What are we going to be kind of like making the gap between those that have the best services and the worst even bigger? So I do think that policy can have a huge impact on access and outcomes in healthcare.
Thank you so much.
I guess that I do agree with everyone, and I want to underline the issue that these tools being gathered together, even if I'm so repetitive on this regard, it's crucial, because we are communicating something that is happening online. It's happening right now. Coalitions have a strong commitment to tackling this. As a fact, we are enter into decisions of how in our own silos, in our own regions, we deal with the same problem. So we are in a dimension in which the design thinking of how we make proper decisions, especially in public health policies, I work straight to that point. According to public health policies, in which you go from research, development, and market access, you need to gather not only the proper information, but to involve all the stakeholders in the decision making. And if there is another issue, the open government, the peer review on research, those things that can understand the ecosystem of how everyone in a responsible and ethical basis should share data, at least one, with the responsibility of the user of that data to anonymize that data. But data itself is nothing. Data has to do if that adequation of data is involved to the benefit of the person. So being selfish in a way of keeping information, it's something that I guess that it's going backwards rather than onwards. And I work especially with ethics. So the general idea is not about sharing data or not accepting community of data. And the only way to work the polis at the ancient Greece is to share. We are in an anthropological dimension, and pandemia showed that. So I celebrate these coalitions places where we can speak on this regard.
Thank you. And we have one question. We will come back to the future and also how we imagine moving forward. But we have also a question from the audience. What about the other genders? How much recognition do they get in research? And now I see all of you nodded. So it's a important topic. Karoliina, would you like to comment on that?
Yes, of course, there's a huge gap in research when it comes to the other genders, or sort of it is if there's in research, medical research, there's used to be like very much male-centered. Now it's more including also the female gender, but then of course we are very much lacking the other genders. But it's not only the medical research, of course, it's all other issues related to medical research. And I do like Maria said very much like about how to include all the sort of stakeholders and everybody. And Jenny has talked about awareness. And this is probably one of those things that has to be made aware in all stages related to data, whether it's the app developers, whether it's the medical professionals, whether it's the policymakers. So there is still, this is one of the most, I don't know, to me it isn't obvious, but for many it is not the obvious gap that there is. But this is something that has to be sort of be made aware everywhere. And I would say, of course, there's more and more acknowledgement of this, but comes slowly. And we do also know that if we have some sort of a data, it tends to reproduce sort of the ideas inherent in the data. And because we only have the binary gender more or less in all the history of our data, it actually requires a lot to get enough data also from the other genders.
Yeah, I think you said that, yes, it seems some things might seem obvious to us. And of course, like, we know and acknowledge the problem, but I think, like, indeed there is a problem, and I believe that many people simply don't know that things are a bit different than we imagine. So I'm very happy to talk with you, and also looking into the future. So now we talk about this sex segregated data, lack of maybe or misrepresentation of women in research, misrepresentation of the information about the other groups. Yesterday we heard a very good quote that the data is the best weapon, and we also heard from, for example, the Ireland representative that now we have to start the war on disease with data. But we know that we need good quality data, of course, also to power AI solutions and so on. So it's not only about the amount, it's not only about the volume of data, but also really the good quality data. So tell me, all of you, the question, like, if you think about that and short-term future, what questions do we still need to ask about the sex disaggregated data? What are still important things to consider in this area?
The standardization, in my point of view, the standardization, the informatics standardization, because we are going towards the language that we are dealing with. And for instance, the audience made a very clever and proper question. And what about other genders? And that's why, if we can standardize something, we can really measure the grade of representativeness that this person has, because as a fact, it's a person that we do not include this person. He's out of the decision and out of the benefit too. So I guess that interoperability, as well as standards and data sharing, that's well known as data for good policies.
Mm-hmm. Standardization, data sharing. Jenny?
Yeah, thanks. I guess I'd answer the question just perhaps thinking particularly about digital health startups. I think that I was thinking really carefully about what data needs to be collected. I know it can be quite a challenge, particularly kind of when thinking about the onboarding process. Like, you can't ask millions of questions, because you might lose people. But I think it is really important to ask questions like this, because ultimately then you get the evidence information at the end in terms of the impact of your product and service on different groups of people, and how it can help them. So you've got to make it easy. I think you've got to really understand what terms you should be using, such that you can capture all genders. But just really see the benefit of it that from a business point of view, that it's so important to be able to have that, because there are lots of innovative businesses out there that their kind of sole purpose is about improving healthcare for particular groups. And so I think that, and that's really exciting in this space that we're working in.
Mm-hmm. Thank you. And Karoliina, do you want to comment? What other questions we need to ask?
Maybe just to turn it a bit around, we all know the possible benefits there are in gathering data and using it, but also we have to ask the critical questions as well. Is all this worth it? What kind of data should we gathering? What kind of constructions of people are we making with this data? And these have to be going along with all the sort of a positive forward-looking questions as well. We need to critically reflect what we are aiming at and doing at.
Thank you. And we also have a question from the audience. The question reads, how can we check what kind of standards were used in clinical trials or platforms development for the medicine we are taking or products that we are using? Can we somehow, so we also, of course, talked about the issue of trust a lot in the different sessions, and how can we trust that what we are taking is safe for us?
Well, first step, you have the general consensus all over the world is the product on medical grade, whatever it is, should be approved by the Food and Drug Agency, for instance, if you want to reach the access market. That product that will enter into contact or involve people and in a balance of risk and benefits should have a check, could be auditable, could be checked in terms of quality, because the premise is do not harm. So you have standards of quality, how to deal with this. There is a proper assessment from agencies. So it's not so free. You cannot reach the market access so simple. That's why there is a technical assessment as well as sustainability assessment, as well as efficiency, non-risky, and all lot of facts that have to do with the health technology assessment. In that health technology assessment, we analyze the standards. So the standardized information that you can open, even an data-driven technology for health, in which you can open the algorithm and check if it is ethically grounded. So we have those rules, but those rules should to accomplish quality standards and informatics standards. So nowadays, to have a proper device or a medicine that we call technology assessment or technology device for medical grade, you can check if it is gonna be acceptable or not. So, and even you can move from market access. So it is something that every citizen can do all over the world. And that's why ethics in research committees have a bidding opinion in which they say, well, this is not the proper protocol, or this is not the proper assessment. And it happens during all the time, even with medicine or clinical guides. So, or with, I don't know, other devices. All medical grades need to be approved by governmental authorities, and that's our terms of quality and interoperability.
Thank you so much for this response. And going towards the end of this interesting discussion, we have one question about the role of policy here at the global, but also country level, not only individual institutions, but maybe I would combine this together with my question about imagining, like if we can imagine the future where the data gaps no longer exist. So what would need to happen between now and this bright future? What actions are needed to improve this data quality and service delivery, and maybe then combining this like on the individual level, also on the practice level and on the policy level? What would be your recommendations?
Making decisions with all the stakeholders.
Making decisions with all stakeholders, and also I think then understanding who those stakeholders are and that this matters. Mm-hmm.
Maybe accepting that there will always be some sort of a bias, and we just constantly have to reflect on the data and our processes and practices, because society changes, medicine changes, people change. There will become sort of a new biases in the data that we cannot currently expect that there are. So we have to be reflective and reflexive all the time.
Oh, thank you. This is very good to remember that, yes, we always have to be aware and be mindful about the, and monitor the world. And Jenny, what would be your recommendation?
Yeah, I think those were great points. I think it's about always looking at different healthcare conditions through those lenses and working out, what are we collecting the right data, and then are we acting on it? What's it telling us that we need to do differently?
Thank you so much. Thank you so much, Karoliina, Isabel, Jenny, for joining me for this discussion. And as I said in the opening, that this is not the feministic voice. It's not only about the justice and fairness, as we heard from the speakers. It's only also about safety. It's about the proper research, resource allocation. It's about fighting the health inequalities. And ultimately, it's about also the services and products and medicines that we are all using. And it's not about gender bias, meaning women's bias, but also men's, like having the proper representation of men, and data about men, and also other genders. So I will leave you with this message, and also like, let's be aware and let's assume responsibility for the good quality of data as researchers, as the policymakers, and as individuals. So thank you so much for this discussion.
Thank you, Karoliina.
Thank you.
Thank you.
Thank you all. Bye.